facial nerve. It has a lot of components. It has motor component, parasympathetic, special visceral efferent component, general visceral efferent parasympathetic component, and visceral sympathetic component. We will discuss them one by one. Which nuclei are related to it? It contains, okay, it contains main motor nucleus. This is the special visceral efferent one that supplies all of the muscles of the facial expressions, all of the muscles that have origin in pharyngeal arch. These are the special visceral efferent fibers. We will discuss the muscles that include all of the muscles. Let me take a minute break here. Okay, let us take it from there. Special visceral efferent fibers. These are the ones that are going to supply the muscles that are derived from the first pharyngeal arch, that are the muscles of the mastication. Then there are two muscles that are the muscles in the attached to the styloid process. Then there are muscles around the ear. Okay, let us continue. We were talking about the we were talking about the main motor nucleus that is like the muscles of facial expression and some other muscles that are supplied by that. Then there is a parasympathetic nucleus. These will be general visceral efferent fibers. There are two nuclei. There are two nuclei parasympathetic. The one that is responsible for salivation, the one that is responsible for lacrimation. These are responsible for that. Don't worry, I will upload a better version of this video. I'm local recording it also. Okay. Then there is this nucleus, and then there is sensory nuclei. The sensory nuclei are both mostly special visceral afferent. The taste sensation is mostly coming from the tractus solitarius. And then there are some fibers you might have read about it while reading about the supply of the external ear, about the supply of the eardrum. You must have read about them. These are the general somatic afferent fibers. These are the going into the spinal nucleus of trigeminal nerve. There are connections, especially we have to talk about the connection of the main motor nucleus especially. You see, main motor nucleus of the facial nerve, it is divided into two parts. The part that is supplying the upper half of the face, the part that is supplying the lower half of the face, the upper facial division, the lower facial division. Now, the part that is supplying the upper half of the face, it had the same story as we discussed in our preamble. It is getting input from both cerebral hemispheres. It is getting input from both cerebral hemispheres. However, the part that is lower one, it is a special one. It is an exception because it is getting fiber only from the contralateral side. There is no input from the same side. Now what happens is that if there is a lesion of the facial nerve nucleus itself. If there is a lesion of the facial nerve itself, this is a lower motor neuron type lesion, and the same side of face gets paralyzed. Same side of face gets paralyzed. It's the lower motor neuron type lesion. There will be complete ipsilateral flaccid palsy. Simple as that. The nerve has been interrupted. The area of supply will be non-functional. So there will be no forehead wrinkles. There will be no ability to shutting of the eye, and there will be absence of nasolabial fold, and the mouth will be pulled towards the healthy side. There will be drooling from that side. That's the lower motor neuron lesion. And lower motor neuron lesion will be in the case of the injury of the nucleus itself, like in the medullary syndromes, pontine syndromes, pontomedullary angle syndromes, or the facial nerve itself. However, if any injury is above the facial nucleus, in the midbrain, in the internal capsule, in the corona radiata, in the cerebral hemisphere itself, there is a stroke. If there is a stroke, if there is a lesion above the pons, what happens is that only the lower division gets affected. Why? Because the innervation from that side of the hemisphere, the contralateral side of the hemisphere, is interrupted, but there is nothing to reciprocate for it from the same side. So lower division gets paralyzed. It suffers upper motor neuron type palsy. However, the part of the facial nucleus that is supplying the upper half, that remains intact. Why? Because it is receiving these fibers from the same side. So that person will have the intact upper half of the face, but non-functioning lower half of the face. So if you see a person with proper wrinkles and ability to close the eye, but with the drooling of mouth and the absence of nasolabial fold, you will immediately recognize that it is due to the upper motor neuron lesion. It is due to any lesion that is above the facial nucleus, that is above the pons. So that is something about facial palsy, and there is one spelling mistake right here. So that is the same thing, and the same story goes for the hypoglossal nucleus. इसका भी part होता है, the part of the hypoglossal nucleus, we will discuss it then. Facial nerve, it had different nuclear connections. The main motor nucleus, it is getting fibers mostly from the cerebral cortex, and it is getting fibers from the reticular formation also. It is getting fibers from the reticular formation also. Cerebral cortex will lead to your voluntary movements, your voluntary movement of muscles, and reticular formation will have different pathways for unconscious smile and expressions that you have that you encounter. And that's a very interesting phenomena in the upper motor neuron type palsy. When there is a stroke, you cannot smile. The person cannot smile because the corticonuclear fibers are not reaching the facial nucleus. There is no voluntary smiling, but emotional smiling may be there because they are not exactly coming from the corticonuclear fiber. They are coming from other pathways, including the reticular formation. So emotional smiling may persist. Parasympathetic nucleus include the lacrimatory nucleus. Lacrimatory nucleus, these are getting fibers from the hypothalamic fibers, hypothalamus. These include the emotional crying. The autonomic, the from the higher centers, the lacrimatory nucleus are activated, or they may get fibers from the neighboring pathway like trigeminal nerve, corneal reflex. It is getting fibers from those nuclei, like lacrimatory nucleus. It may be getting from trigeminal nerve. You get dust in your eye and you start lacrimating. Then there is superior salivatory nucleus. Superior salivatory nucleus is the one that is responsible for salivation. The same pathways, it may be receiving fibers from descending autonomic fibers. You think about some tasty food and you get salivating. Pavlov's experiments. So descending hypothalamic fibers, autonomic fibers, or direct reflexes from the taste pathway. Any connection from the solitary nucleus, nucleus of tractus solitarius, that are receiving the taste fibers, they have a reflex connection to these nuclei and they will lead to lacrimation. Sensory nuclei. Sensory nucleus is the solitary nucleus, nucleus of tractus solitarius, and this is receiving the taste fiber, especially from anterior to two-third of the tongue, anterior two-third of the tongue. And this is, as we mentioned in the preamble, it is will be the second order neuron, and the fibers from it, they will cross the midline, move up and relay in the thalamus, and that will be ventropostero-medial nucleus of the thalamus, and they will go to the brain. So that's the facial nerve, its nuclei, its connection. Now let us talk about a difficult topic, that is its root. Facial nerve has a very peculiar root in the brainstem, that it makes a facial colliculus. It goes back, winds around the abducens nucleus, and then exits from the pontomedullary junction. Here you see it exiting from right here, pontomedullary junction. On the medial aspect there is cranial nerve number 6, on the lateral aspect there is cranial nerve number 8. All of these notes are taken right here also. These are moving between pontomedullary junction. From there it moves to the internal acoustic meatus. Let me move you to the 3D model. Okay, here this is the facial nucleus nerve that is moving along with, this is the facial nerve main component. This is the called sensory component, that is called nervus intermedius, because it is running between the main facial nerve and the vestibulocochlear nerve, that is the nervus intermedius, the part that is containing the parasympathetic and sensory fibers. Then it enters this area, that is the internal acoustic meatus. That is the internal acoustic meatus. To see, it goes to the inner ear, and to see what is happening in the internal acoustic meatus, it is going into the petrous bone. Let us make this bone transparent. So here we can see it moves there, and in the inner ear it is encountering this ganglion. This is the geniculate ganglion. This is the geniculate ganglion, and the geniculate ganglion, here you can see that the main nerve is going in this way. Let me make a few adjustments. Okay, you can see the main, this is the geniculate ganglion, this is the facial nerve coming here, this is the main continuation of the nerve, and this branch that is separating right here, this is called the greater petrosal nerve. It is going there, and it is going to the foramen lacerum. It is going to the foramen lacerum, and it will go to the supply the pterygopalatine ganglion. So that's the main continuation of the nerve. Let us follow that. It moves in the ear, it moves above the inner ear. You can see it is moving above the cochlea, it is moving above the vestibule. From looking for the other things, let us look at it from the outside. Let us look at it from here. Let us try to get access right there. So here you can see you are looking through the transparent middle ear. So here is the facial nerve, that is here it is running at the junction of the middle ear and inner ear. So it is running in the medial wall of the middle ear, in the lateral aspect of the inner ear. So it has two direction movements. It moves backwards in the medial wall of the middle ear, then it moves downwards in the posterior wall of the middle ear. And here two branches are very important. One branch is not shown very clearly here, the branch that supplies this muscle. This is the stapedius muscle. This is the stapedius muscle. This muscle is supplying this stapedius bone. It prevents against hypermobility of stapedius bone. It helps in dampening of the sounds. So that's one branch. The other branch that is exiting in the ear is this one, that is called the chorda tympani, that we just saw in the previous slides. Chorda tympani. It is carrying the parasympathetic and it is carrying the taste fibers. Parasympathetic is general visceral. Of sorry, parasympathetic is general visceral efferents. Parasympathetic is general visceral efferents, and taste fiber are special visceral afferents. They are the chorda tympani. It moves along the lateral wall and it exits the anterior wall of the middle ear. So that's the facial nerve there. Then it exits from the this foramen, that is stylomastoid foramen. Let us bring that bone to the same position, in the solid position, and here you can see it exiting through this foramen. This foramen is the stylomastoid foramen. This one. This is the stylomastoid foramen. The stylomastoid foramen, the important thing to know is that it is very much protected because it has on the lateral aspect this styloid process. On the medial aspect there is this styloid process. On the lateral aspect there is this mastoid process. However, the thing that you have to remember is that in newborns, the styloid process is not well developed. Not mastoid process, I'm sorry for that. The mastoid process is not well developed. So it at this point the nerve is vulnerable to injury during forceps deliveries. Here, it gives two branches before entering the parotid gland. This branch that is going back, supplying the posterior auricular muscle and supplying the posterior belly of occipital belly of occipitofrontalis. And then there is you can see these two muscles attached here, the stylohyoid and posterior belly of digastric. So these are branches supplying these muscles. So these are branches of facial nerve. Moving on, it enters the parotid gland, and in the parotid gland it divides into 5 branches. It supply becomes the temporal branch. It gives rise to the zygomatic branch, the buccal branch, the mandibular branch, this one, and then there is cervical branch. These supply all of the muscles of the facial expressions. We can see them, we have discussed them in detail, muscles of facial expression, in the lecture of the face. You can see that lecture in our channel. So that's all the thing we discussed in the 3D model. That is all mentioned right here. And all of these things can be seen in this picture from the Netter's Atlas. These are the pictures from the Netter's Atlas. You can see it. These are the look. Sorry, you can focus on this picture. You can see it running in the medial wall of the backwards in the medial wall of the ear, downwards in the posterior wall of the ear, giving the nerve to the stapedius, giving the nerve to the chorda tympani. These branches are the can be shown here, stylomastoid foramen, then all the other branches. This is a very good schematic diagram that is shown in the Netter's Atlas. I know it's a very big picture, it can be overwhelming, but do open the Netter's Atlas and you can see all of these things. It has shown the different fibers that are originating. The main facial nucleus, the nervus intermedius, the two joining just inside the internal acoustic meatus. Then there is geniculate ganglion, and the parasympathetic fibers going to the lacrimal gland. They exit from the geniculate ganglion, as we saw there, greater petrosal nerve, and go all the way to the pterygopalatine ganglion and supply the lacrimal gland. Not only that, the mucosa of the nose, the mucosa of the palate. Then in the middle ear moves back, moves down, and in the middle ear two nerves branches are given, the branch to the stapedius and the branch to the chorda tympani. And chorda tympani branch is the one that exits in the ear and goes down to the infratemporal fossa, join the lingual nerve, give the parasympathetic supply to the submandibular sublingual gland, and give the taste fiber to the anterior two-thirds of the tongue. Then it moves down further, exits to the stylomastoid foramen. Before moving the parotid, two branches are given. The one to the back supplies the muscles of the ear and the occipital belly of occipiter frontalis. Downwards, it supplies the muscles of the stylohyoid and posterior belly of digastric. And then there is muscles that are a whole of the muscles of facial expression. These are the branches given by the all the 5 branches that are originating from the parotid gland. So these are the list of all the fibers branches. We have discussed them. Greater petrosal branch, that is the one that is going to supply the lacrimal gland, nose and palate. Nerve to stapedius. Chorda tympani branch going to supply the salivary glands, parasympathetic and taste fibers. And posterior auricular branch, posterior belly of digastric, stylohyoid and terminal branches. So these are all the branches we just discussed. This is a schematic diagram to understand the parasympathetic fibers especially. This is from the Gray's Atlas, and here you can follow the facial nerve. The branch going to the lacrimal gland, it gets separated from the before entering the middle ear, that is greater petrosal nerve. The greater petrosal nerve join the sympathetic fibers coming from the internal carotid artery sympathetic plexus, the deep petrosal nerve, and they enter the nerve of pterygoid canal. Both they enter that nerve of pterygoid canal, they enter the pterygopalatine ganglion. From there, they are spread in many directions. They get to the palate, they get to the palate, they get to the nose, they get to the lacrimal gland. And this is the relay area. And the other fibers of the parasympathetic fibers, back, down, chorda tympani, joins the lingual nerve, relay in the submandibular ganglion, go and supplies the submandibular, sublingual, and dorsal lingual glands, minor salivary glands. And the taste fibers are also carried along the way. So this is all about the facial nerve. I have made a summary for all of the areas. I have denoted the pathway of the movement of nerve in the blue, the branches in the pink or orange color, and the functions in the gray area. So it moves from pontomedullary junction, enters the internal acoustic meatus, moves above the inner ear. At that point, there is a geniculate ganglion. Greater petrosal nerve separates from here, moves as greater petrosal, then becomes nerve of pterygoid canal, goes to pterygopalatine ganglion, and supplies the lacrimal gland, nasal and palatine mucosa. Then the further continuation goes into the middle ear, gives two branches, nerves to the stapedius, nerve to the chorda tympani. Nerve to the stapedius helps in dampening of the sound, and chorda tympani branch goes and joins the lingual nerve, and they give rise to supply to parasympathetic to submandibular sublingual, and the taste fibers are given to the anterior two-thirds of the tongue. I have written 1/3, it is actually two-thirds of the tongue. That is two-thirds of the tongue. Then there is stylomastoid foramen, and from here, before entering the parotid gland, there is posterior auricular and muscular branches that gives rise to these 4 muscles and the parotid gland. My reason for going into so much detail in this is you are asked that the person is coming with these symptoms, which where does the facial nerve, where is the facial nerve damage in this patient? For example, if the facial nerve is damaged at pontomedullary junction, all of the functions will be lost. For example, if the facial nerve is damaged in the middle ear, there will be Bell's palsy. The muscles of the around the ear and back muscles, there will be loss of the functions of the chorda tympani. That is, taste will be lost, salivation will be lost, dampening of the sound will be lost, but lacrimation will be intact. That is how you will know that the lesion is in the middle ear, but after the inner ear. Similarly, if there is an injury during forceps delivery, there is an injury here. So there will be loss of these functions, but the salivation will remain intact, the taste will remain intact, the dampening of the sound will remain intact, the lacrimation will remain intact. An injury is occurred during parotid gland surgery. So there will be palsy of the facial nerves, but these muscles will remain intact. Salivation, taste, dampening, lacrimation, these will remain intact. So by understanding these things, you can pinpoint the site of lesion of the facial nerve just by hearing the symptoms and signs of that person, getting to know the signs and symptoms of that person. So that's the theory behind the facial nerves. So you are over the major hump, and then